Regarding foreign body ingestion, there are 5 very important etiological factors, and they are age, loss of protective mechanism, carelessness, narrowed esophageal lumen, and psychiatric etiology, which play an important role in the ingestion of any foreign body. Foreign body is the most common cause for injury-related deaths in children who are less than 1 year of age, an incidence rate up to 80% in children less than 5 years. Loss of protective mechanism can occur in patient who is alcoholic, having an epileptic seizure, or who has lost consciousness. Carelessness occurs when there is improper mastication or hasty eating. Narrowed esophageal lumen can occur in terms of carcinoma or tumor or any structure, and psychiatric is suicide. A very important key factor is that food, for example fish bone and coins, are the most common causes for foreign body ingestion. Now further talking about the factors that influence the severity of foreign body ingestion: the degree of obstruction, the size, shape, nature of the object, and the location where the object is present. Now obstruction could be partial, it could be complete. Regarding the size, it could be a small foreign body or the foreign body could be large. If the foreign body is small, simply local anesthesia, mirror illumination, and curved forceps would help remove the foreign body. But if the foreign body is large, it cannot be removed with local anesthesia. A proper general anesthesia and endoscopic removal will be opted for. Similarly, if the shape is such that it is liable to cause perforation, it must be removed immediately. Talking about the nature, if the object is sharp, it may cause perforation. Regarding the location where the foreign body can get lodged, there are 5 of them. Number 1, tonsils. Number 2, base of the tongue. Number 3, posterior pharyngeal wall. Number 4, piriform fossa. And number 5, esophagus. There are 3 points which one must know regarding small MCQs: that younger the age, more proximal would be the foreign body lodgement. The most common point for foreign body lodgement is just below the cricopharyngeus. The most common site of instrumental perforation of esophagus is just above cricopharyngeus. Now in terms of the different factors, they will determine whether the foreign body is present in the upper airway or it is present in the lower airway. If it is present in the upper airway and causing obstruction, features like gagging, choking, discomfort just above the clavicle, dysphagia, and drooling of saliva can occur. Now drooling of saliva is dangerous because it can lead to aspiration and lead to pneumonitis. If the object was small, it was not that irritative that it initiated cough, it will enter the lower airway and it will cause obstruction. And the features would be absent breath sounds, respiratory distress, and epigastric discomfort. All of these points were the symptoms. There is only one sign of foreign body ingestion, that is tenderness over the site where the foreign body is present. Now let us talk about the investigations which we will ask for in a patient who is likely to have a history of foreign body ingestion. Number 1, X-ray. Number 2, bronchoscopy. Whenever we ask a patient to have an X-ray, he should be given proper instructions to have posterior, anterior, and lateral views of neck, chest, and abdomen, so that we can have proper information about the type of the object, the site of the foreign body lodgement, so that we can have a proper management plan. On X-ray, there could be 2 types of objects: a radio-opaque object or a radiolucent object. A radio-opaque object can be present either in the esophagus or air passage, and on different views, for example in PA view and lateral view, it will appear in different forms. A foreign body in esophagus in posterior anterior view will appear in the form of a coronal plane, but an esophageal foreign body in the lateral view will be in the form of an edge. Let me show you an actual X-ray so that we can have a permanent concept about these 2 points. As you can see, this is an X-ray in which a radio-opaque object is viewed In a coronal plane, this is the lateral soft tissue neck X-ray in which the foreign body in the esophagus appear to be on the edge side. Now, the second type of object, the radiolucent object, it will appear in the form of an air bubble in the cervical esophagus in the lateral soft tissue neck X-ray. Now, once we have made proper diagnosis about the site, size, and shape of the foreign body, from X-ray, we can use our definitive investigation, that is bronchoscopy, which will not only be diagnostic but also therapeutic. Regarding the management, I have divided it into two groups, pediatric age group and adults. Talking about pediatric age group. In pediatric age group, the very first thing we have to see is that is the child coughing or not. If the cough is present, then it is likely that the foreign body will be removed by the cough impulse. No intervention is required, only normal diet with no purgatives and stool examination for spontaneous removal is the treatment of choice. But if the child is not coughing, then we will see what is the age of that patient. If it is less than 1 year, back blows and chest thrusts can be helpful, but if the child is more than 1 year, Heimlich maneuver will help. Secondarily, in adults, foreign body ingestion is dealt with cricothyrotomy, rigid bronchoscopy, or endoscopy. Then, operative removal is required only when